now move further. Now, what are the criteria for hospital admission in a case of severely malnourished child? Now, see there. All children we cannot admit to our hospital because our hospitals have limited bed. There's no point or no problem if there are enough bed available. Okay, so we need to have certain criteria, and these criteria are: if a child weighs less than 60% for age, see here, less than 60% for age with edema. Now every one of you know, if the child weight is less than 60% and with edema, what we call that? Yes, what we call that?
Marasmic kwashiorkor.
Grade 3 marasmic kwashiorkor.
This is marasmic kwashiorkor. Marasmic kwashiorkor, according to Wellcome Trust classification. Because in Wellcome Trust classification, we take weight for age and whether there is edema or not. Now see here, less than 60% for age along with edema. This is marasmic kwashiorkor. But if your teacher asks you about Indian Academy of Pediatric classification, then it falls under grade 3. You're right. It depends which classification you use here. Okay. If that child is having severe dehydration, we need to admit and give IV fluid in the hospital. We cannot do that at home. If the child is having severe diarrhea and less than 60%, this is a serious problem, needs to be admitted. Hypothermic child needs to be admitted. If the child is in shock, very serious condition, needs to be admitted all the time, and different types of shock can occur in that child, either hypovolemic shock or septic shock. Systemic infection is always a very serious feature in a malnourished child. The child can die quickly because of infection. So we need to admit and manage appropriately. Jaundice, bleeding disorder, if the age is less than 1 year and if there is a persistent loss of appetite, also we have to admit and manage in the hospital. These babies should not be discharged at home quite early. Now, one important point here, children with severe wasting or edematous undernutrition. Okay, children with severe wasting or edematous undernutrition also has to be admitted in the hospital. Now see there, edematous undernutrition. Remember the meaning of undernutrition according to Wellcome Trust classification. It falls between 60 to 80% weight for age with edema. It is not a marasmic kwashiorkor, but still we need to admit this child in the healthcare center. One exception here is severe stunting alone may be managed in the community. Stunting means decreased height, and that decreased height can be there because of chronic malnutrition. So the child doesn't look that very sick. The child is still stable. So we can manage stunting, okay, in the community. That is the important point. Let's move further. Now, what are the conditions with poor prognosis in a severely malnourished child? If these factors are present, then it shows poor prognosis. And those are serum albumin less than 1 gram per deciliter. Now, every student should know what is the normal level of serum albumin. Then only you know how low it is, isn't it? So what is the normal level or value of serum albumin? Yes? Anybody?
1 gram.
Normal level.
Gram per day.
That is 3.4 to 5.4 gram.
3.4 to 5.4 gram per deciliter.
Okay, very good answer. Okay, I'm getting good answers here. Now see this, very good, excellent. It is, okay, 3.5 to 5.5 gram per deciliter. This is one of the way of answering. And some textbook mention it gram per liter also. Okay, it's the same thing, gram per liter or gram per deciliter. So if I use gram per liter, then probably this value will be 35 to 55 like that. So this is the good way to remember. Now see that this is the lower limit of the serum albumin. If it is less than 1, this is very, very low. So it shows for prognosis. Total bilirubin more than 6. Now, can anybody tell me what is the normal value of total serum bilirubin? Yes, what is the normal value? TSB should be less than 1 milligram all the time. Okay, it is less than 1 milligram. Less than 1 milligram per deciliter. It should not be more than that. Okay, so in this condition, it is more than 6 milligram percent or 6 milligram per deciliter. It's the same thing. This is a bit high. And serum sodium, what is the normal value? I want to get this answer. Yes, please.
135, 145.
45.
Excellent. 135 to 145 milli equivalent per liter. 135 to 145 milli equivalent per liter. These are the important points. That's why I am explaining this. Okay. But every lab value you don't need to remember. Please do not put a lot of pressure on your mind. These days, every lab test will have normal value on the side. You can always compare there. Interpretation is important here. Okay. But these are so common thing. So when we practice these things, it automatically sticks in our mind. We'll never forget them. So this is the way. And in this condition, serum sodium is very low here. Here, less than 120. Okay. So let's move further. Now, we have come to a very important part of this topic, that is how to manage a child with severe malnutrition. Okay, this is a very important discussion, and in any exam, trust me, in any pediatric exam, some of the question will definitely come from here, because we belong to South Asia, and malnutrition is very, very common in our part of the world. Now, there are 3 important headings by which we discuss this type of management of severe malnutrition child: initial treatment, rehabilitation, and follow-up. So let's talk about them one after other. Now, if you understand this slide, okay, the whole discussion will be very easy for you. So please pay attention here. This is the initial treatment, here is the rehabilitation, and here is the follow-up. Look at the time frame here. Okay. The first week, okay, first week after hospitalization or hospital admission is the initial treatment phase. First 7 days. After that, the rehabilitation phase start. It may last for up to 6 weeks. 6 weeks means 1.5 months. And after that, the follow-up phase starts, which may last very long, up to 26 weeks or even longer. It is never the accurate one, okay? It is always a variable point. See here? So week 7 to 26. The follow-up can be quite long, extensive. Now, what we do in the initial treatment phase, what we do in the rehabilitation phase, and what we do in the follow-up phase. Let's talk about that. So see here, treat or prevent hypoglycemia, hypothermia, and dehydration. That has to be done in days 1 to 2 of hospital admission, the first and second day. If till now there is no hypoglycemia, but there is a very high chance of getting hypoglycemia, you need to prevent it. If it has already occurred, you need to go for the treatment. That's the meaning. We'll talk about each of these. Correct electrolyte imbalance, it should be started from from the day 1. See there, right from the hospital admission, it should be started, and it is a continuous process. Throughout the rehabilitation, it should be continued. Treat infection, it should be done immediately. We try to find out which infection is there, okay, if possible, and start the therapy. correct micronutrient deficiencies. Now see here one very important point. In the first 7 days, okay, of hospital admission, you don't give iron therapy, but after that you give iron just like any other micronutrient. Now I want to ask you a simple question here first. What do you mean by a micronutrient? Yes, anyone? What is micronutrient, guys? Anybody?
Body need it trace amounts like
Good.
iron.
Good.
They are the nutrition
Those
that are required for
nutrients which are needed less than
that element.
100
Good. So you
m.
know a lot of the students are answering, okay, and they are showing a lot of interest. Very impressed here. Yes, Imran. Imran, you are saying something. Yes, go on. I can't hear him properly. So okay, so let me answer this. But many of the students have already answered correctly. Okay. So see this micronutrient. Micronutrient means those type of nutrients which we need in a very small amount. In a very small amount. The name itself suggests micronutrient. We don't need them in a large amount. We need them in a very small dose. Like vitamins and minerals are called micronutrients. Vitamins, fat soluble vitamin, water soluble vitamin, like A, D, E, and K, they are fat soluble, and vitamin B and C are water soluble. So they are micronutrient. Iron, calcium, zinc, phosphorus, okay, selenium, cobalt, copper, these all are called micronutrient. These are minerals. Okay, don't forget them. Now the important point here. In the first week of hospital admission, you don't give iron therapy because we need to control the infection first, then only iron therapy can be given. Otherwise, the iron which we are giving is utilized by that bacteria and they proliferate further inside the GI tract. Please mute yourself. So what I'm saying here, the iron which we are giving in the first week, okay, are utilized by the bacteria, and then those bacteria can further proliferate. The infection will be even more than before. So let's control the infection first and then start the iron. Never forget this. Another type of activity is feeding. Now see there, right from the day of admission, we should start the feeding, and it is an ongoing process. Later on, the feeding should be increased. Okay, the feeding should be increased. Why? To catch up the lost weight. To recover the lost weight, we need to gradually increase the feeding. This is an important point. Another type of activity we need to go for is stimulation of the child, either emotionally or by some of the stimulation, some other type of stimulation, like playing music, okay, singing song in front of the child, playing with the child. So all these things really help in the recovery process. And this will go on right from the day of admission till the follow-up period. And then we prepare for the discharge. See there, after the first week is over, we can discharge the child to the rehabilitation center. Now, some of the students may want to know what is rehabilitation, but I'm sure many of the students know this already. Rehabilitation means we'll try to bring that child back towards the normal stage. What was the stage of the child before malnutrition occurred? After we treat, okay, the dangerous problem, we feed the child, we stimulate the child, okay. So this is called rehabilitation. So these all things comes under management of malnourished child. Let's move further. Now let's enter into the each of these. Regarding the initial treatment, we have already known a lot of things now. See here, to treat or prevent hypoglycemia and hypothermia, both prevention as well as treatment. Till now, if they have not happened or occurred, we go for prevention. If they have already happened, then we go for the treatment. To treat or prevent dehydration and restore the electrolyte balance. This is also important point. So let me underline and explain to you. Okay, so hypoglycemia and hypothermia. Another one, to treat or prevent dehydration and restore the electrolyte balance. Now, which are the common electrolyte we are concerned here? Yes, which are the common electrolyte? Who can answer this, please? Anybody? Is also one important point here. Can you see or can you hear me? Yes? Yes, guys?
Yes,
sir.
sir.
Yes?
Yes, sir. Can hear you.
Because there is no response.
Yes, sir.
There's no response. That's why. So I'm asking you a question actually. Okay, see here. What are the common electrolyte? Which are the common electrolyte which we are concerned and which we need to restore in this type of babies? Yes? Which type of electrolytes are there?
Sodium and potassium, sir.
Potassium and calcium.
Good.
Sodium chloride.
Exactly. Sodium, potassium, and calcium. These are the three main one. Okay. Sodium, potassium, and calcium.
Sodium chloride.
Very good. Sodium and chloride. Sodium always, okay, whenever we talk about sodium, chloride always follow that, okay? So you can simply say sodium, potassium, and calcium. Even if you say chloride, your answer is correct. Now, let's move further. Another, part in the initial treatment is to treat incipient or developed septic shock if it is already there. Now, incipient means, okay, it is almost going to develop there. Developed means it is already there. Now, let me talk a little bit about it. In yesterday's class, we talked about septic shock. Remember, this severely malnourished child are immunocompromised. So any type of infection is common in them. And if we do not diagnose it in time, they can quickly spread everywhere and result in septicemia as well as septic shock. So we need to diagnose it. Otherwise, we may lose the child because of septicemia and septic shock. That is the meaning. We'll talk about this. Start feeding the child. We have to do it right from the day of admission. Okay, treat the infection and to identify and treat any other problem like vitamin deficiency, severe anemia if it is there, and heart failure if it is there. Okay, diagnose it in time and go for the treatment. Okay, let's move further. Now, one of the very important complications of severe malnutrition is hypoglycemia. Now, what is hypoglycemia? What are the symptoms and signs, and how do we manage it? Let's talk about it. When the blood glucose level is less than 54 milligram per deciliter or less than 3 millimole per liter, it is known as hypoglycemia in a malnourished child. Less than 54, which is equal to less than 3 millimole per liter. This hypoglycemia may be caused by different reasons. Some important ones are a serious systemic infection in the child can lead to hypoglycemia. Another reason, the child was not fed for a relatively longer period, like 4 to 6 hours. Remember, this child or children are malnourished. So there is already a high chance of hypoglycemia in them. On the other hand, if the parents have not fed their child around or more than 4 to 6 hours, there is a high chance of hypoglycemia. Now, one small explanation we need here. Why infection can lead to hypoglycemia? Who can tell me that? Yes? Anybody? Anyone? Any student?
So maybe because of it cause inflammation, which may lead to decrease blood volume
Okay.
and cause
Okay.
edema.
Okay. Good. I'll come to you. Okay. Good. At least here he's answering something. Anybody else? Okay. Let me answer.
The bacteria which cause infection, which use the increased peripheral glucose utilization, sir.
Okay. Now some of the points I'm getting here. Very good. So listen, all of you, please listen. Listen, carefully here. What happens as a result of infection? See there, as a result of infection, this is a stressful condition to the body, and during that situation, glucocorticoid and epinephrine or as well as norepinephrine hormones are released. We all know that. In the beginning, they will cause hyperglycemia in the beginning, but it all depends on what is the reserve glucose in the body. In case of malnutrition, there is no reserve. The glycogen is not present in a higher amount inside the liver in a malnourished child. So even if those hormones are present, without glycogen, glucose cannot be synthesized, and the chance of gluconeogenesis is also very less there. As a result of this, later on, there is a high chance of hypoglycemia. Never forget this explanation. Let me repeat this once again. In the beginning, for a transient period, there is hyperglycemia, but that cannot last longer because the storage form of the glucose, which is known as glycogen, is very limited in case of malnourished child. Without enough glycogen, the glucose concentration will fall after some time, leading to hypoglycemia. This will be further aggravated if the child was not fed for more than 4 to 6 hours. Now, what are the signs of hypoglycemia? One of them is hypothermia. Hypoglycemia can lead to hypothermia very commonly. That is low body temperature, which is less than 36.5 degree. The child become lethargy. The child become limpless, and there is loss of consciousness. The limpness means there is no tone. The muscle become floppy. The child looks weak, doesn't want to move, looks very sleepy, and in a very severe hypoglycemia, the child may develop coma as well. Sweating and pallor do not usually occur in a malnourished child, which is a very common feature in other healthy children or in other adults. Remember, hypoglycemia can easily lead to sweating and pallor. What is the cause of this pallor? Anyone tell me? Pallor. Why pallor is here?
The anemia.
One is anemia, but in this case, we are talking about hypoglycemia, okay? So it is not caused by anemia here. But you are right. If I ask, severe, this is because of sympathetic stimulation. Both sweating and pallor occurs because of vasoconstriction. Now, sweating, as a sympathetic stimulation, there is sweating, we all know that, and the same mechanism is responsible for vasoconstriction, which leads to pallor. But in severely malnourished child, there is lack of iron in the diet. There is lack of other micronutrients also, so there is high chance of anemia. So you can always answer this if the question is general, but in this case, the pallor is caused by vasoconstriction. Now, those are the things which I was talking, but they are not very common in malnourished child. Okay, I was just giving explanation for the pallor and sweating here. And unfortunately, if they are present in a malnourished child, it is very easy for us to diagnose, but they are not commonly found. Now, how to treat it? Okay, that's a challenge here. Treat immediately without lab confirmation. Do not waste any time. If you suspect this is a case of hypoglycemia, go for the treatment, because there is no harm, okay, by giving glucose to the child. There's absolutely no harm. So why you wait? Why you waste time? Give the glucose if you think. That's the meaning. If the child is conscious, we go for different types of management. If the child is unconscious, we go for different type of management. Okay. Now pay attention here. Give 50 ml of 10% glucose or sucrose, or give F75 diet by mouth, whichever is available most quickly. So whatever is available in front of you, you give that to the child, because the child is conscious, the child can still drink. There's no real danger of aspiration. That's why even F75 diet can be given by mouth. Now you may be wondering, what is the meaning of this F75? Okay, so please pay attention. This F75 is a special type of milk. It's a special type of milk which has 75 kilocalorie of energy per 100 ml of the solution. This is the meaning. Okay, 75 kilocalorie per 100 ml of the milk. This is F75. Later on we'll talk about F100, that is 100 kilocalorie per 100 ml of the milk. This is a very commonly used feeding way in the malnutrition center. Now on the other hand, if the child is unconscious, how do we manage? Now see there, in an unconscious child we cannot give oral, we have to go for IV. So 5 ml per kg of 10% glucose is given by IV route. So this is the dose, 5 ml per kg. If the child is 10 kg, I will give 50 ml of 10% glucose intravenously. After that, we give 50 ml of 10% glucose or sucrose by NG tube. NG tube is a nasogastric tube. We have already given good amount of glucose by intravenous route. After that, I can manage it by NG tube feeding also. And then you continue frequent oral or NG tube feeding with F75 diet to prevent a recurrence of hypoglycemia. You don't leave it there, okay? Because this is just a acute type of treatment. You continue to feed the child with NG tube feeding, and the appropriate diet is F75. I was talking about the management of hypoglycemia before the break. Now hypoglycemia can be managed by two different ways. If the child is conscious and drink, we can give some food like F75 to the child, or we can also give 10% dextrose or sucrose. Okay, and if the child is unconscious or cannot drink or eat, then we have to treat by intravenous route, and after that continue the feeding whatever the child was getting. At the same time, infection is one of the very important cause of hypoglycemia, so go for the treatment of infection. That is very, very important one. Let's move further. Now hypothermia is another very important complication of severe malnutrition. So let's talk about which children are susceptible to develop hypothermia. They are infant under 12 months of age, very small babies, children with marasmus. Now marasmic baby, they don't have subcutaneous fat. The subcutaneous fat is atrophied. Okay, it is not there, so they can directly lose heat from the body. There is high chance of hypothermia. If the babies have large areas of damaged skin, which mainly seen in kwashiorkor now, kwashiorkor babies have a peeling of the skin, they have infected skin. So who knows, a large part of the skin may be lost, and easily the heat can be dissipated outside. At the same time, serious infection can also lead to hypothermia. Infection can lead to fever as well as hypothermia. Never forget this. But in case of severely malnourished child, the chances of hypothermia are more common than the fever. Regarding the diagnosis, we need to measure the temperature, and temperature measurement, okay, is done by different route. One is rectal temperature, another is axillary temperature, which is called underarm temperature. So rectal temperature, usually if it is taken, it shows less than 35.5 degrees centigrade, and underarm temperature is less than 35 degrees centigrade. Then we diagnose hypothermia. Now, how a child should be warmed? This is regarding the management. Use the kangaroo technique. Okay, kangaroo technique. Now, I'm sure you know this animal called as kangaroo. Okay, it is very commonly found in Australia. Probably this is the national animal of Australia as well. Now, just remember how that mother kangaroo is taking care of the baby kangaroo. Okay, there is a a pocket, isn't it, like thing in the belly of kangaroo, and the baby just stay inside that pocket, and the baby will get constant heat from the mother body or mother skin. The same type of principle will be applicable if a very small child is hypothermic. Okay? Mother should not wear any cloth, okay, on the anterior part of her body, especially between the breast, and that baby is tightly kept in contact on the mother's skin, and both of them are wrapped with a cloth. This is called kangaroo technique, which is very commonly employed in different malnutrition center, or even in case of neonatal center. If a very small baby, neonate or infant, is suspected to have hypothermia, this is the way we have to treat. This is the excellent way. It increases the bond between baby and mother as well, and a baby will get heat from the mother. Another one, clothe the child well, including the head or rest of the body. Don't ignore the head and feet. Okay, use the cap and the socks very well. Place a heater or lamp nearby the child so that the child will get enough heat, but don't keep it so nearby that the child will get burned. We are not saying that, okay? So what I'm saying is the child should get enough heat, because this is a case of hypothermia. The rectal temperature must be measured every 2 hourly during rewarming, and make sure it has come back to the normal. All hypothermic child must also be treated for serious systemic infection. Infection can lead to both hypoglycemia as well as hypothermia, so be careful. Who knows, this may be one of the manifestation of severe infection in the body. So we need to be quite vigilant regarding this. Similarly, check blood sugar, okay, and manage it, and feed the child every 2 hourly, because feeding is very much essential for the production of heat. The child should get enough nutrition, then only heat can be produced in the body. A hungry child, a malnourished child has high chance of hypothermia. So feed the child every 2 hourly. This is how hypothermia is managed. Now, one important a question I like to ask all the time to my student whenever I take this topic is, if the child is having fever, for example, okay, let me explain like this. If the child is having fever, many of the parents believe if they dip the child or soak the child in icy cold water or ice cold water or freezing cold water, it will help the child. What do you think? Should we expose the child to freezing cold or ice cold water when the child is having fever? Who can answer this?
No, sir, because it may lead to hypothermia.
No, sir.
Okay.
No.
Yes, please go on. Yeah, I'm listening. Yes. So the answer is no, right? But do you know the reason for that? What is the reason?
Sir, because it will lead to the reflex type of hypothermia, sir, causing the hypothermia in the baby.
Now, okay, Now all of you, please pay attention to this explanation. This is very interesting. The child is already having fever. Every one of us believe if we expose the child to colder temperature, it will help the child. Okay, that it has got some truth, but I'm talking about ice cold temperature. That is quite, hazardous for the baby. And the reason is, very cold temperature will lead to vasoconstriction. The blood vessels will be constricted, and to lose the heat from the body, vasodilation should occur, not vasoconstriction. So what I am doing here, by exposing that child who is having fever to the ice cold water, I am further increasing the temperature in the body, because heat cannot be lost now. So if you want to expose that child to the water, just room temperature water is the ideal one. Do not put very cold water on the body. Now similarly, why I am bringing that point, okay, now let's come to our topic. Similarly, in a very hypothermic child, do not expose the child suddenly to very high temperature. You should never do that. It is always a process of gradual rewarming rather than the a sudden type of rewarming. Now the dangerous thing about sudden rewarming is, okay, there is more amount of blood flow when we give heat to the body. More amount of blood flow to that specific part. Now there is generation of oxygen free radicals, and oxygen free radicals are quite damaging to the tissue. So the conclusion here is, both hyperthermia and hypothermia should not be treated suddenly. Gradual rewarming or gradual loss of temperature is warranted. Now let's move further. We talk about infection. What's the chance of infection in the malnourished child? What are the common symptoms and signs, and how do we manage? Now see there, the chance of infection is very common in malnourished child because they are considered immunocompromised. So any type of infection, skin infection, subcutaneous tissue infection, any organ infection, those are very common. And one very important point is, there is no fever or signs of inflammation if infection is there. Then how do we diagnose it, isn't it? That's another big question. Without fever or without signs of inflammation, how infection is diagnosed? So this is a really challenging thing. And one of the very important point here is, high index of suspicion is required. That means if a child with severe malnutrition is admitted to our hospital, we always believe this child is having infection inside the body. So we do proper investigation and treat the child with broad spectrum antibiotic. Malnourished child with serious infection may only become apathetic or drowsy. Now apathetic means he is not showing interest in the surrounding, no interest at all, and drowsy is lethargy. This may be just the feature of infection in the child. These are also commonly seen in hypoglycemia. That's why all children with severe malnutrition like kwashiorkor, marasmus and marasmic kwashiorkor should routinely receive broad spectrum antimicrobial treatment when first admitted in the hospital. Okay, so we'll talk about that. What are these broad spectrum antimicrobial agents? Now see here, according to World Health Organization or WHO, there is first line treatment in this type of children, and these first line treatment are, okay, see here, these first line treatment are cotrimoxazole. Now you all know cotrimoxazole is a primitive type of antibiotic. So which two antibiotics are present in cotrimoxazole? Yes, please. It's a combination, isn't it? So which two antibiotics are there in cotrimoxazole? Who can answer this?
Trimethoprim and sulfamethoxazole.
Very good. Excellent answer. So I'm sure many other students also know this from your pharmacology knowledge. Sulfamethoxazole and trimethoprim. The combination is cotrimoxazole. So WHO says we should give this medicine for oral, okay, twice a day for 5 days in a minor type of infection. Or even if there is no apparent signs of infection, we need to start this antibiotic. But if there is a severe type of infection or already some type of complications occurs as a result of infection, then we do not rely on this antibiotic. We need to use antibiotic cocktail like this. Now see here, ampicillin, okay, here ampicillin, one aminoglycoside, see this, ampicillin or amoxicillin, they belongs to the same group, gentamicin and metronidazole. This is an excellent combination. Ampicillin or amoxicillin belongs to penicillin group, gentamicin belongs to aminoglycoside group, which is a very important drug for gram-negative organisms, and metronidazole will cover our anaerobe. So it is plus minus, means if you do not strongly believe anaerobes are not responsible for the infection, you don't need to use it. But if you believe, just go for it. That's the meaning. You don't need to remember the dosage now, okay? If some students really want to know, it is for them. Let's move on. Now, if there is no response within next 48 hours, then you add chloramphenicol. This is what World Health Organization tells us. You have used all those antibiotics which I have just mentioned. Within 48 hours, you reassess the child. If there is no improvement or response, add chloramphenicol. Now, what is chloramphenicol and what is the danger of using chloramphenicol? Anybody? What type of? Yes, please.
Aplastic anemia. Aplastic anemia.
Aplastic anemia. Very good. I want that answer. Excellent. So chloramphenicol is a broad spectrum antibiotic. Okay, it covers many different organisms, especially bacteria, of course. But one of the dreaded complication or side effect, I should say, or adverse effect of chloramphenicol is aplastic anemia or bone marrow suppression. That's why the use of chloramphenicol is very, very limited these days. The younger generation doctor, okay, we don't want to use chloramphenicol to our patient. This is a reserved drug these days. If it is necessary, then only we go for it. Otherwise, there are lots of other options. Treat for specific infection if identified, like if it is pneumonia, go for the treatment of pneumonia. If it is pyelonephritis, go for the treatment for that. If it is abscess, go for the treatment. So accordingly, we need to choose the antibiotics or modality of treatment. And one important point, all malnourished child should receive measles vaccine when admitted to the hospital. Now, I like to, explain a little bit here. What type of vaccine is measles vaccine? Is it killed or live vaccine? Anyone? What type of vaccine is this? Killed or live? Okay, probably you have not gone through this. This is a live vaccine. Okay, this is a live vaccine. So that means in a very immunocompromised patient, we don't give this type of live vaccine. But this is considered one of the exception here. In case of malnutrition, though it is immunocompromised situation, we still give measles vaccine in this case, because if measles occur in the malnourished child, it will further lead to severe malnutrition, and sometimes the child even may die because of the complication. So just to prevent that child from the complication of measles, we need to give vaccine if the child did not get any vaccine before. This is always important. Okay, we give measles vaccine at 9 months of age, and one booster dose can be given later on. If those are already completed, you don't need to repeat it. But if the child did not take it before, at the time of hospital admission, we need to give 1 shot. Now, what are the daily record we need to keep in the hospital? This is done by the nurses, but before taking round, you need to just go through this. So what is the weight of the child? We need to take it every day. Is the child is gaining weight or not? Especially in kwashiorkor, the child will lose weight in the beginning because of the fluid loss. In marasmus, the child start to gain weight right from the beginning. Take temperature. Make sure that the child is not febrile or hypothermic. It is usually taken twice a day. Pulse rate, respiratory rate are taken, okay, many times a day. How many stools the child has passed in a day? Is the child having diarrhea or not? Important question. And according to the definition of diarrhea, if the child has passed more than 3 times and the consistency of that stool, okay, takes the shape of the container, then it is called diarrhea. Means it is a watery type of stool. How many episodes of vomiting is there? We need to ask this question and record. How much urine has been passed by the child? Record it. Okay, we make sure the child is well rehydrated. Is the child having cough or not? And whether the child is anemic or not. These are the different type of examination or daily record you need to check. Now, there is something known as food intake chart. Now see this food intake chart. Here is a date, here is a time of feeding. If the child is getting, feeding 4 times, so you write the appropriate time and then mark it. What type of feeding you are giving, write that. How much food you are offering to the child, write that. What is the amount taken by the child, you write that. This is the job of the nurse. We doctor, we don't need to do this, okay, but we need to check it. Otherwise the child, how we know the child is getting better or not? How we know the child is eating enough or not? So this has to be examined or checked. Estimate the amount of vomited after the child eat, whether there is any watery diarrhea or not. So this is called food intake chart. Now we are going to the important parts of this management. If vitamin A is deficient in the child, in case of malnutrition I am talking, okay, how we treat it. And another important point is also here, there is high chance of vitamin A deficiency in a malnourished child. Till now that has not happened. So how we prevent it? Or in other words, what is the prophylaxis of vitamin A deficiency in severe malnutrition? That is one question. And another one, if the child has already developed xerophthalmia or proven vitamin A deficiency, then how do we manage it? Now see here. Severely malnourished child are at high risk of developing blindness due to vitamin A deficiency. There is no doubt about it. And this is the prophylactic dose. 50,000 international unit is given orally for infant who are less than 6 months of age. And this is a very common question you will be asked in the exam. Okay, so I want my students to remember this. 50,000 units, international units, orally for infant less than 6 months of age. 100,000 international unit orally for infant till 1 year of age. And 200,000 or 2 lakh international unit for children more than 1 year of age. So this is called prophylactic dose. Now, if the child has already developed clinical signs of vitamin A deficiency, which is known as xerophthalmia or night blindness, same dose should be given but more frequently. That is, on the first day, repeated on the second day, and the third dose is given at least 2 weeks late. So you can easily call it 0, 2, okay. A 0, if you call first dose as a 0, then second dose can be called as 1. But if you call first dose as 1 then you can call 2 here. Okay, it's up to you. And the third dose is at 14th day. So 1, 2, and 14th day. So this is how treatment of vitamin A deficiency or xerophthalmia can be done during severe malnutrition. The dose is same. So what I mean here, if the child is 2 years of age, see here, I will give 200,000 international unit on day 1. I'll repeat the same dose on day 2, and I'll repeat the same dose on day 14. And this is how I will treat the proven or established xerophthalmia in this type of children. Now, what about other vitamin deficiency? What we do? Give folic acid. Folic acid is another very important vitamin. Okay, folic acid. Under which group folic acid belongs? Which group? Yes.
Vitamin B9.
Very good. Vitamin B9. Excellent. Okay. So it is belongs to vitamin B complex family. B9 folic acid. So it is given 5 milligram orally on day 1, and then 1 milligram orally per day thereafter. All diets should be fortified with vitamin B complex and vitamin D, E, and K as well. This is called fortification. Fortification means you add, okay, you add vitamins there, or on a regular diet you give certain food which are rich in vitamin. This is the meaning of fortification. Give multivitamin drop to the child, and these are the dosage: 0.3 ml once a day if a child is less than 1 year old, or 0.6 ml, double the dose, for more than 1 year. These are multivitamin drop. They contain different types of vitamin together. These are commercially available preparation. And vitamin K also should be given. Now, if the child is having very severe anemia, how do we manage? Now, very severe anemia, okay, in this condition is defined as less than 4 gram per deciliter of hemoglobin. Less than 4 gram per deciliter. If I tell this in gram per liter, it will be less than 40. It is equivalent to packed cell volume of 12%. So what I mean here is, do not give packed red cell until and unless the child is severely anemic. Now, what is packed red cell? What do you mean by that? Anybody?
It is measurement of
Hematocrit.
protein of the blood.
That is known as a hematocrit, sir.
Good. It is hematocrit. Very good. It is hematocrit. Or in other words, it doesn't have any plasma, isn't it? It only has RBC. Only the RBC concentration or concentrate you are giving. Now, another question comes immediately. Why don't you want to give whole blood to these babies? What is the risk? What is the danger here if I give whole blood? Why I want to give packed cell here? Anyone? Anybody know the answer?
It will cause edema, sir.
Okay. Now see here, pay attention. In this condition of severe malnutrition, the heart is also atrophied. The heart, just like any other organ, is also atrophied. If I give large volume, heart cannot handle that volume, and that heart can develop congestive heart failure. To avoid this, if volume is not necessary, why we give? Why we overburden that kid with the extra volume? That is the reason. So whole blood means what? Everything is there together. There is plasma also, there is RBC also, there is WBC, platelets, clotting factor, everything together. We don't want that type of blood in this case. This is a case of very severe anemia for a long time. So only give packed red cell, avoid unnecessary fluid. And this is how it is given. Give 10 ml of packed red cell or whole blood per kg of body weight slowly over 3 hours with furosemide at the start of the transfusion, if hemoglobin concentration is less than 4 gram per deciliter or less than 40 gram per liter. Now, this whole blood is only given if packed red cells are not available, okay? And after giving whole blood, don't forget to give furosemide, because this furosemide is a loop diuretic. Whatever fluid is there in the whole blood, furosemide will flush it out, and that is always important here. But furosemide is not necessary if you only give packed red cell, because it is not necessary. There is no extra plasma there. This is very important point. I have already explained this point. Do not give iron during the initial phase of the treatment, as this iron therapy can have toxic effect and it may reduce the resistance to infection. The bacteria may utilize this iron and they further proliferate. They further can spread to the different parts of the body. So iron is not given during the first week of therapy. We control the infection first with antibiotic, then only iron should be started. Now, let's talk about congestive heart failure in a severely malnourished child. Now, why it develops first, and if it develops, how we manage it. Now, see there, this congestive heart failure usually is a complication of overhydration. The overhydration can occur because of excessive IV infusion or because of whole blood transfusion. Just now I talked about that. Or if we give standard ORS solution too much to the child. So see here, if we give excessive IV fluid like normal saline or lactated ringer, if we give whole blood, or if we give standard ORS solution to the child thinking that the child is severely dehydrated, it can lead to heart failure in that child. So let me explain a little bit regarding this. Now, what is ORS? ORS means what?
Oral rehydration solution.
It is a solution which contains sodium, glucose, and potassium.
Absolutely, very good. All of you have the concept. ORS is an oral rehydration solution. It has got sodium, potassium, chloride, okay, and all those things together. Glucose is also there. Now, this standard ORS means it is usually, okay, the WHO has prepared this for cholera patient, and this ORS is mainly devised for the adult one. If we give the same standard ORS to a malnourished child, the amount of sodium which is present there, the sodium is present in a 90 millimole per liter there, okay? It is too much for that malnourished child. And if excessive sodium is there in the body, water will be dragged along with sodium. So the child will develop hypervolemia, and it is one of the cause of heart failure. So to avoid that, some other modified form of ORS should be given to the child. Heart failure may be a complication of very severe anemia. Now, okay, this is my habit. I repeatedly ask question to you guys. Why severe anemia can lead to heart failure? Who can tell me that?
Because low
Sir,
supply
it
supply
may
of
be
the
due
blood.
to hemoglobin level or decrease and the heart will compensate the mechanism.
Okay.
So
Anybody
the
else?
heart won't get that much oxygen.
The
Heart work
hemoglobin deficiency is a kidney disease. So there is also cytokines are the production, sir.
Okay. Now, see there, I'm hearing a lot of answers. Very good. Okay, you guys are showing interest. Excellent. And some of the answers are, very near also to the correct one. Now listen. Okay, all of you, please pay attention. This type of questions can be asked in any exam. Now, anemia means the hemoglobin or RBC level is low in the blood. Those are very much essential for the oxygen carrying, okay, function of the blood. In severe anemia, the heart is also getting very low oxygenation. The heart is also suffering. And to compensate for this, the heart will try to pump faster and stronger as a compensatory mechanism. Now, over a period of time, okay, it can handle for a particular duration according to Frank Starling law. Remember that it can handle for a particular duration, but not always. And after that duration is over, the heart will fail. So this is the excellent way to give explanation. So let me repeat again. In case of very severe anemia, the oxygen carrying capacity of the blood is reduced. The heart will also get decreased oxygen. To compensate for that, the heart tries to beat faster and stronger, which can cause heart failure over a period of time. If we give a diet with a high sodium content, there is a chance of heart failure because sodium always draws water along with it, and the baby can suffer from hypervolemia. Heart cannot handle that in case of malnutrition. Heart failure must be differentiated from respiratory infection and septic shock. Now remember, in heart failure, there is tachypnea, there is tachycardia, okay? There is decreased peripheral perfusion in heart failure. There is prolonged capillary refill time, and all those things are there. So sometimes we may confuse this with infection in the body, like respiratory infection and even other infection which can lead to septic shock. A very good examination is necessary. A very good investigation should be ordered, and then only you have to reach to a particular diagnosis and then manage the case. Now, what is the management? Very easy. You just give IV furosemide, IV diuretic, and the most important one here is furosemide, because I want to flush out that excessive fluid from the body and then restrict the fluid until the child gets improved. Now, another complication in case of severe malnutrition is some skin problem, especially in case of kwashiorkor and marasmic kwashiorkor child. So how do we provide the skin care in these babies? If there is candidiasis, you can apply Jensen violet or clotrimazole mouth paint. Okay, this clotrimazole mouth paint is given for the treatment of oral thrush, because candidiasis is very commonly occurring in the oral cavity, and this is the way we treat. We apply this clotrimazole mouth paint in that lesion in the oral cavity, repeat it for a few days. Okay, that's how we go for the treatment. And this other forms of clotrimazole can be applied on the skin if there is a candida lesion. Zinc oxide is applicable in perianal region. It is applied in the perianal region. Now let me explain one of the very interesting phenomena here. In a malnourished child, sometimes what happens, when you start feeding with milk, they cannot digest the milk. Okay, they develop milk intolerance. Now, which type of monosaccharide or disaccharide is present in the milk? What is the name of that?
Lactose.
Lactose.
Excellent. Okay, lactose. It is a disaccharide actually, lactose. So this lactose cannot be digested if that malnourished child just had diarrhea a few days ago. So this is called lactose intolerance or milk intolerance. Okay, now this lactose will be passed distally and it will be converted into lactic acid by the commensal bacteria there. This lactic acid is an acidic substance. So when it is passing, okay, along with the stool, it will burn the anal or perianal skin. Perianal skin means the skin around the anus will be burnt by this lactic acid. The treatment for this condition is zinc oxide. Never forget this. Just apply zinc oxide there and it will take care of the situation. Treat the secondary bacterial infection. This is not the 20, okay? This is secondary actually. Treat secondary bacterial infection, which is very common on the skin, by using antibiotic. And the common antibiotic which we use on the skin are fusidic acid. If you remember, we talked about this fusidic acid as well as mupirocin. Fusidic acid and mupirocin. These are very commonly used in the treatment of bacterial infection of the skin. Systemic antibiotics are given in case of quasi-worker dermatitis if it is a bit severe type of skin infection. Don't only rely on the topical one. Bath the affected area by 1% potassium permanganate solution, and povidone iodine 10% ointment can also be used for the treatment of these skin lesions. So these are the different ways. Don't give iron during the first week of hospital admission or in the initial management. I've told the reason so many times. If we give iron, we will enhance the infection inside the malnourished child because there is high chance of infection in malnutrition. Okay, that's why after we control the infection, then only iron should be started. So oral iron must be given during the rehabilitation phase, and this is the dose of the iron. See here, 3 milligram per kg per day in 2 divided doses. Okay, you can remember this. This is very easy to remember. 3 milligram per kg per day in 2 divided doses, and this is the maximum daily dose, 60 milligram daily for 3 months. Now, when we talk about the treatment of iron deficiency anemia, we'll repeat this again. But right now, I want to say something here. For the treatment of iron deficiency anemia, in 1 month time, the hemoglobin will come back to the normal after 1 month, okay? But we still give it for another 2 months. That is around total of 3 months, because the iron stores are already over in case of iron deficiency anemia. So to replenish or to fulfill those depleted iron store, we need to give iron for a long period of time. Now another type of management, okay, which we specially do in case of rehabilitation phase, but it should be started right from the beginning, is emotional and physical stimulation to the child. And it is usually done by play program. We need to play with the child. We need to show attention to the child. The child should not feel that he or she was ignored. This is very important point. Talk to the child, smile in front of the child, and show affection to the child. This is important for the overall growth and development of the baby. After any unpleasant procedure, the child should be comforted. Never wrap or tie the child. Now, so many examples we can give here. For example, after IV cannula, for any IV medicine, you give IV cannula first, isn't it? That is a painful procedure. The child will definitely cry. So you should comfort the child after that. Never wrap or tie the child. This is unethical. For example, sometimes what we do, after putting nasogastric tube in the child, okay, we tie the hand of the child so that the child will not take that nasogastric tube out. This is unethical. We should never tie the hand of the child. Rather, we should tell the parents, please look after the child. That child will not pull the things out. Okay, even if the child pull it out, do not scold the parents that you are not looking after the child. What are you doing there? Rather, you put it again because it is very necessary. Provide pleasant and colorful environment in the hospital or clinic or in the rehabilitation center. Make sure the toys are available in child's cot and the room, because children, they love toys absolutely. So these toys should be available according to the age group, and play a very, a good type of music which is loved by the children or the babies. So these are important part of emotional and physical stimulation. We should never ignore them. Only feeding or only treating in the initial phase is not enough. Now we have come across to the end of this topic. Now during the feeding, there is some problem occurs now. there is one important phenomena which is encountered during nutritional rehabilitation, and that is known as nutritional recovery syndrome. Now, what do you mean by this and why it develops? Let's talk about it. If we feed that malnourished child with high quantity protein, that means if we give a lot of protein which is more than necessary here, then this particular syndrome will happen. Now what happens here? The hallmark of refeeding or nutritional recovery syndrome is development of severe hypophosphatemia after the cellular uptake of phosphate during the first week of starting to refeed. Means phosphate will enter into the cells, and this is because of the effect of high quantity of protein intake. Now, after that phosphate enter into the cell, very low phosphate is remaining in the blood. That can result in weakness, rhabdomyolysis, dysfunction of the neutrophil, you can see it here, cardiorespiratory failure, arrhythmia, seizures, and even altered level of the consciousness. A lot of these things, okay, are happening in the body if we feed that chronically malnourished child and severely malnourished child with high quantity of protein. And this is the molecular basis, because of the decreased level of serum phosphate. Now, some of the point I like to ask to you here. What is rhabdomyolysis? Yes, guys?
The breakdown of the muscle fibers.
Breakdown of skeletal muscles.
Very good. All the students are answering quite correctly. This is the breakdown or lysis of skeletal muscle, rhabdomyolysis. Other points are quite easy there. Now, other features apart from them, okay, so see there, you can see here now, are hepatomegaly, abdominal distension, ascites, and with or without splenomegaly. Hepatomegaly is more important than splenomegaly, but splenomegaly also can occur. This is probably because of too much fluid collection in the body. Because we are giving high quantity protein, so probably that protein is drawing a lot of fluids in different spaces. Hypertrichosis. What do you mean by that? Anybody?
Excessive overgrowth of hair.
Very good. It is excessive hair growth. Hypertrichosis, excessive hair growth. Okay. Gynecomastia. This is enlargement of the breast tissue in male babies. In female, we don't use this term. Parotid swelling and eosinophilia. And then, now, why these features along with the other features are occurring here? Probably because of excessive estrogen and variety of other hormones which are released by recovering pituitary gland. So pituitary gland also recovers because of excessive feeding. So it is synthesizing more hormone, and if FSH and LH are increasingly coming from the pituitary gland, there will be increased estrogen secretion in the body, which may lead to all this problem. So just know nutritional recovery syndrome can occur if we feed excessively high quantity of protein to that recovering child. Now, we have moved to the last part of this topic. This is a big topic and very important one. Now, what are the criteria for failure to respond to the treatment? Now, what do we mean by this? We have done everything according to the protocol. Different hospital has got different protocol and we are following that. But still, the child is not responding to our treatment. So which are those criteria? If they are present, they tell us the child is not responding to the treatment. These are called primary failure to respond and secondary failure to respond. Now let's discuss about them. If the child failed to regain appetite by day 4 of admission, If the child failed to regain appetite by day 4 of admission, this is primary failure to respond. Maybe we have missed something. Maybe the infection was not treated. Okay. If the child failed to start to lose edema by day 4, especially quasi-worker and marasmic quasi-worker child, they should lose edematous fluid first, then only they can gain weight later. If that doesn't happen by day 4, this is primary failure to respond. If edema is still present by day 10, this is also primary failure to respond. And if there is failure to gain at least 5 gram per kg of body weight per day, at least that much of body weight gain should be there. Even by day 10, if that doesn't happen, this is also known as primary failure to respond. So these are the criteria. Now, what is secondary failure to respond? This usually occurs during rehabilitation. Earlier, the child was gaining weight fine or well, but because of some problem, the child failed to gain at least 5 gram per kg of body weight per day for 3 successive or consecutive days. That is called secondary failure to respond. The term secondary means earlier the child was fine. Okay, he has already developed good appetite, he was already gaining good weight, but suddenly because of some illness, some diarrhea, vomiting maybe, some illness, infection, the child has failed to gain weight according to the criteria. Now another big question, we need to find the reason now why the child has failure to respond. Now see there, these are the frequent causes of failure to respond. Let's talk about them. There may be some problem with the treatment facility, like poor environment for malnourished children in our hospital or care center, and we are ignoring that. There may be insufficient or inadequately trained staff. We need around 8 to 10 nurses, but there are only 1 or 2, and they also don't know how to feed the child. So this is a serious problem in the facility. Sometimes there are inaccurate weighing machines. The weighing machines are there, but they are not properly calibrated. Okay? The needle is not pointing at 0. Then also it is a faulty type of thing. And then the food prepared in the hospital is not proper, or the nurses is not giving the food correctly. Then also the child will fail to respond. So these are the problems with treatment facility. Now, what are the problems of individual children? Why they fail to respond? Probably insufficient food is given to them. Okay, very little amount of food is given. Maybe they are having some vitamin or mineral deficiency, which should be, supplemented, and we have missed that. Probably they are having malabsorption, some problem in the small intestine, which is not absorbing the food. Rumination is vomiting. Okay, they are regurgitating. There may be infections in the body. Any type of infection or infestation can lead to failure to gain weight, like diarrhea, dysentery, otitis media, pneumonia, tuberculosis, UTI, malaria, some helminth in the intestine, and HIV and AIDS. You can add so many other, okay? This is just few of the common causes. So any infection in the body, there is failure to gain weight. Now, can anybody tell me why there is failure to gain weight in the presence of infection? Yes? What may be the reason?
Sir, because they failure to response.
A lot of energy is used.
Lot of energy is used. Very good. One important point. I got it. Now listen here, okay? All of you please pay attention. In the presence of infection, it is called high metabolic state of our body. So in case of high metabolic condition or state, we burn up the calorie. We need more calorie during that time. But what is happening here? The child is not getting enough. So how can the child gain weight? Even if the child was not malnourished before, excessive demand but decreased supply will lead to failure to gain weight. So this type of explanation you can easily give. And if there are some serious underlying disease, then also the child has failure to respond. So these are some of the practical points we are talking about. Okay, so as a doctor, we question ourselves, we question our diagnosis, but at the same time you have to think about these things as well.